agenda item, which is it either you or Paul? Let me have a look. I can't remember. It's Richard. Yeah.
Thank you, Chairman. I think the report's fairly self-explanatory, but perhaps just like to alight on the aspect of winter resilience for the NHS. Board members will recall last time both the Chief Executive and myself remarked on the performance over the Christmas period and the fact the NHS has stood up quite well over that period, and we now have the statistics to prove it. So this report includes the December analysis. Performance on the A&E 4-hour wait was still not where we'd like it to be, but nevertheless at 91% was significantly better than the same period last year. So in December 14, that equivalent figure was 89.9%. And we've seen similar better performance in ambulance response times as well. And one statistic, which isn't in the report, but I thought colleagues would be interested in, is in the previous winter, in December 14, we had a lot of problems with excess trolley weights, 12-hour trolley weights, and we actually had 186 of those in December 14 alone, and the equivalent figure for December 15, still regrettable, but was 29, so a significant reduction. So I think that does bear out the fact that this winter the NHS has proved more resilient, it's coped better. We've had much fewer extremes of serious operational issues and performance, and I can say that actually prevails up until this point. Clearly, again, we'll see next month the performance figures for January. So overall performance is not where we want it to be, but it's certainly in a better position than it was this time last year. And I think I'll just make the final point that, as I said in the previous item, we're in the middle of the operational planning round, working very closely with our colleagues in NHS Improvement, and we're making sure that every local system has a performance trajectory around elective and emergency targets, mental health targets, cancer targets for next year. Where they're currently behind those targets, they've been asked to deliver recovery plans and demonstrate through next year's plans how they're going to get back on course. So that's a key focus of our joint endeavour at this time.
Any questions? Moira?
Chair, can I ask Richard about the transfers of care and what's his sense of that significant increase, and also does acute care mean not social care? Because the implication is that that's gone up as well, but proportionately, as it were.
The detox area is a challenge, and it's a difficulty in a number of ways. One thing that I can report is that we've set up a cross-government initiative to work with social care agencies and NHS to make sure we really improve our position on this. I mean, the reported position currently is around 3.5% of our beds are blocked at any one time, which is a lot in terms of what it means in terms of the ability to smooth discharge patients, but it's still 3.5%. In other words, 96.5% of beds aren't blocked in that way. I think one of the concerns that I have personally, and it's a personal concern, I haven't got the evidence for it yet, but there are a lot of patients who are in beds who similarly could be discharged more quickly, who aren't yet classified as a DTOC. And that is because to be classified as a delayed transfer of care, you need to have a multidisciplinary assessment, both by the NHS professionals and by the social care professionals. You've decided this patient needs to be discharged, but the delay is it actually hasn't happened yet. There are many patients who are deemed medically fit but haven't been through that process. So one of the things that we'll be trying to do, working hard with providers and social care, is to do those assessments earlier and more quickly, so make sure they're ready for discharge. But the negative consequence of that, we might actually increase the number of people who are within that definition. So it may look superficially, we may look like we're getting worse when actually we're improving, because we're identifying those people earlier and moving them through. So I think we need to work with the cross-government initiative and forecast what that impact's going to be. But as I said, there is a slight danger that superficially things might look poor in a short time, but it actually would be because we're actually intervening earlier and making sure these discharge packages are ready, and then making sure they're actually executed.
Okay. Any other questions? Richard, there are a number of these. Whilst the overall position, I think, shows improvement, for which is great, and thanks as always to all colleagues across the NHS for their efforts in this. There are still a number where either we're not hitting the target or we're only just hitting the target. RTT probably the most visible in some respects. And I guess the board should have some assurance on what's being done to try and improve our performance there.
Yes, indeed. Well, as I said, the main assurance is through the planning process to make sure that every individual community is working really hard on these targets. much clearer this year, I think, than they have been in the past about the demand and capacity relationship. I think some of the planning has been not as strong as it should have been. People have identified a 12 months worth of activity which they know needs to be delivered, but they haven't really thought month on month, week on week how that will be delivered. And when the system gets under pressure, though that activity is not delivered in terms of the planned way, really making sure that's carefully thought through. At the same time as well, we're trying to support local systems through national initiatives, looking at things like there are many procedures that perhaps have limited clinical effectiveness. There's good evidence of that, and make sure that people are aware of that, that both referring clinicians are aware of it and receiving clinicians are able to look at their treatment options. There are also many better alternatives than some of the traditional referrals into hospital. Just an example, many of the musculoskeletal conditions that people suffer from, direct access to good physiotherapy could be a good alternative and take demand off the hospital part of the system. So we're working through a programme that's called Right Care, which is an evidence-based programme that supports CCG commissioners to help to make those decisions. So it's a mixture of local operational work to improve things, but also some national support to help people to actually plan in the best way.
And I've been fortunate to have spend some time with the Right Care team and also to see some of the things in action. I have great hope for that, particularly as an awful lot of it doesn't involve any investment, doesn't involve any change in the sense of working practices, but it's absolutely things that can have a dramatic impact on patients, on reducing variability, on greater consistency, greater quality. And therefore I know we're rolling that out as fast as we can. There's a skill issue and everything, but there are ways in which we can make a real difference, I think, there. Okay, thank you.